Yes, you guys are waiting for the main attraction. So thank you all for being part of this webinar series. This is the Florida Foot and Ankle Fellowship Seminar Series, webinar series, I should say. And basically, we represent Florida's fellowships, or the majority of Florida fellowships in the state of Florida, in combination with FPMA and the Florida Podiatric Medical Society, who is the educational arm of FPMA. And so basically, we run these seminars monthly, and we have usually invited fellowships from across the state of Florida. And next month, we actually have next month and the month after, we have some invited fellowships from out of state. So we'll have some, invited fellowships from across the nation. Just while we're on that subject, June 23rd, next month, save the date, we are having, I believe, American Health Network Foot and Ankle Surgical Fellowship as our guest. And then save the date for July 28th. We are having, who is that? Oh, the Orthopedic Foot and Ankle Center Fellowship, Dr. Prissel as well. Michael Miller will be on June 23rd, and Mark Prissel's program will be July 28th. And then we want to say thank you to all of our all of our sponsors. And the sponsors over the course of this past year have been Paragon 28, Stryker, OMI, MedArthis, Organogenesis, TriMed, and we have a new sponsor as well, Subchondral Solutions. So we thank all of them for the support of our webinar series, and this, we call it a Roundtable of Excellence. So trying to show off the quality of our fellows and give them an opportunity to present what they're doing at their fellowships, and some interesting cases as well. Myself and Dr. Perler are on the call. We are the co-founders, but we have wonderful fellowship directors and fellows in the state of Florida that are on this call usually as well. So today we are welcoming Dr. James Lucito. He's the fellowship director for the Barry University School of Podiatric Medicine. He's fellowship programs in podiatric sports medicine, and his fellow Suni Jhanji. And you guys take it away. We are looking forward to hearing what you have to say. So thank you very much for being part of this series.
Thank you very much. Does the fellow generally presents the information, or I'll be here, or how do you generally work the programs?
You can, okay. So sometimes we do a mixture. So you guys can, Dr. Losito, this is an opportunity for you to speak, or your fellow. If you would like him to present most of the didactic and then you comment along the way, that's okay too. You can run it how you want. This is going to be interactive and entertaining, and you can throw in all your pearls of wisdom, because I'm sure you have many. So however you want to run it is fine.
You be the judge. No, thank you. Sonny, take it away.
All right, sounds good, Doc. Hello, everyone. My name is Sonny Jhanji, currently the fellow under my fellowship director, Dr. James Losito. We are based out of HCA Florida Hospital, Mercy Hospital in Miami, Florida. And we are the Barry University School of Podiatric Medicine Fellowship in Sports Medicine, with 2 team affiliations, with professional team affiliations with NRCF Miami, as well as the Miami Heat NBA basketball organization. And the title of our presentation is Athletes' Ankles, Stabilizing the Unstable. Should I just say next slide, you guys? No, thank you. So just to start off with some quick anatomy, just some ligamentous structures. You can see in the images here. We know our lateral ligaments, ATF, CF, PTF, the syndesmosis, anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, as well as the medial deltoid ligament and the components, and the bifurcate ligament. Next slide, please.
I think, talk about the ligaments there, and I know that some of the literature's come out that shows how the connection between them all and why the ATF is so critical. I know Sonny and I have discussed that a lot, why the ATF is kind of the keystone, and why is that so? Because they're all interconnected. And I think that's very interesting literature to kind of explains how the outcomes have been very similar when just the ATF is corrected. So, but anyway, Sonny, go ahead.
Sure. And then just an image here kind of depicting the lateral ligaments. Very important for us to focus on these ligaments because when dealing with an athletic injury, you know, this is what's most commonly going to be affected, as we'll see in the next couple slides. Continuing on, the most common sports injury, most common acute injury is going to be an inversion ankle sprain. So obviously we're kind of going to be focusing on those three ligaments in that area. Plantar fasciitis being the #1 chronic injury, and some other common injuries being runner's toe, navicular fractures, shin splints, tibial stress fractures, and Achilles tendon injuries. Here an image just showing our, plantar fasciitis image, kind of depicting the pathology there. Go ahead, next slide, please.
You could throw in Jones fractures, of course. I think if we all hear of an athlete having a fracture in the foot, more likely than not, it's a Jones fracture. But so you could have included that in that list as well as far as sports injuries. But go ahead.
Sure. We've seen a couple. We just saw Caleb Martin, who just we took an X-ray of his foot and didn't even know he had a previous Jones fracture with some good fixation for the heat.
A lot of people do.
Oh yeah. As well as Juan Soto, a baseball player from the DR. So lateral ankle sprain, what is a sprain? It's a stretching injury which may involve attenuation, partial or complete tearing of the lateral ankle ligamentous structures. This is 40% of all sports injuries. So again, most common injury in all sports. The lateral ankle ligaments are affected 85% of the time. Medial is 5%, the syndesmosis is 10%. And so once again, very important to focus on this anatomic area. And just an image here kind of showing, the mechanism of the sprain. And then go next slide, please. Thank you. So some other things to consider, any hereditary ligamentous laxity disorders, Ehlers-Danlos syndrome, Marfan syndrome, Turner syndrome, a fracture, for example, ankle fracture, Jones fracture, sinus tarsi syndrome, osteochondral defects. Subtalar instability is very important. We'll talk about that later, as well as perineal tendinopathy. And then again, are you dealing with an acute ankle injury or is this chronic ankle instability? Because two very different things. And we've got Jimmy kind of considering all these other things. And next slide, please. So the anatomy of the ankle inversion injury. This involves the shape of the talar dome. This kind of animated image on the right here, kind of depicting dorsiflexion and plantar flexion at the level of the ankle joint. As we know, the talus is going to be wider anteriorly than posteriorly. So as you can see, it's going to have decreased stability in the frontal plane when the ankle is in plantar flexion, just due to the anatomy in the area, the osseous anatomy. And this is just two more images, one showing, obviously on the right, showing plantar flexion, just so you can visualize the lateral or the frontal plane instability. And just touching on biomechanics, things we all know, but the subtalar joint has a 2-to-1 inversion to eversion ratio. The ankle inversion is going to be generated at the subtalar joint, and just a few images kind of depicting that as well. I did this for Dr. Sutherland. Biomechanics, so the contributing factors: ankle equinus, gastrocnemius and soleus weakness, forefoot to rear foot deformity, and a transverse plane abnormality. And just the image here kind of depicting the equinus and the gait cycle and things we all know and how that can be play a role in the treatment plan and kind of addressing.
I mean, Sonny's learned as well, the role of the podiatric physician to a particular sports team. It includes clearly the surgical correction of problems, but it also understanding the biomechanics. And really, that's what we bring to the table. I know that with the orthopedic doctor that I work with, Dr. Harlan Selznick, an outstanding doctor, was the dream team physician years ago for the Olympic basketball team, a full supporter of our profession. This is what he looks to me for the most. We can discuss Jones fractures and tibial stress fractures, and we can discuss those. When it comes to biomechanics, what's on this slide, that's not within his realm. It really is what podiatry brings to the sports table, the understanding of the biomechanics and how they play into the generation of injuries. So very important.
No, very important, Doc. And it's surprising for me because obviously I knew we were going to be doing orthosis and things like that for the players, and just to see how much these players, really rely on it too, and it changes their performance. It's pretty amazing, and a lot of times these players go through these orthotics anywhere from 2 to 5 games, Doc.
Yeah, I would say so.
Yeah. So it's been really, really fun to watch the player satisfaction as well this year. Yeah. Next slide, please. So the history, what are we considering? The mechanism of the injury. Can they bear weight initially? History of a previous injury and that treatment and outcome. That's very, very important. Again, is this acute? Is this chronic? And what have they done previously if they had a really bad sprain? So much of, at least how I grew up in Oklahoma. I mean, I played a lot of sports growing up, a lot of wrestling. Anytime you had an ankle sprain, I mean, it's literally walk it off and you're in practice, 30 minutes later. And obviously things are starting to change. And, but again, very important to see what they've done treatment-wise. Was there an audible pop? And again, their weight-bearing status is very important initially. So continuing with some history, was there any inappropriate shoe gear, excessive cushioning, shoe or surface that was irregular, or any other contributory neurological history? One thing, Dr. Losito and I always talk about is, we have, it seems like one of every few patients comes in wearing, these big fluffed up Hokas. And, it's very interesting to see the changes and trends in shoe gear. And a lot of times, it's the wrong shoe for the person, just because of the instability it gives the person.
There's research. One particular article, I know the author felt that any shoe with an air cell, compressed freon gas, kind of, talking about a Nike, he considered that to be a risk factor for an inversion sprain. And the whole concept of cushioning being a solution for problems. I think all the biomechanists, Ben O'Nig being probably the lead person, I know Kavanaugh before him, feel like the whole idea that cushioning is going to improve anything really needs to be rethought. It has been rethought completely. So.
Sure. And then, another point to that too, just like we had a patient the other day, Doc, and we see a lot of runners in those kind of shoes and those big cushiony shoes. Obviously their style of running. A patient we had the other day was a Post style runner, but they just switched to Hokas and having a lot of pain due to the excess cushioning and stability. And it's kind of forcing them to heel strike as well. And so just another consideration.
Yeah, I mean, the right shoe for the running style. Someone runs pose style on the ball of their foot, they're not going to be comfortable in a shoe with any kind of, thick cushioning or any kind of thick midsole. They're going to do better with a more minimal type of shoe that works well with that style of running. And one kind of drives the other. But that's why it's important for us to know about shoes and to know a patient's problem can be purely because they're wearing the wrong shoe for the wrong sport. Or some runners will come in and they've got a Newton shoe and then they have a Hoka and they say, I kind of go back and forth between the two. And you're like, no, you are one or the other. Going back and forth is not, no, with two things that are completely different with how they promote your gait and how you work with those.
So beginning with our physical exam, we're going to obviously take vitals depending on where they're presenting, but you always begin proximal, always, start with the proximal area of the fibular, fibular neck and head, beginning at the least painful areas, and then continuing on to the next slide. We see the other areas of palpation, definitely the lateral malleolus, obviously our 3 lateral ligaments, ATF, CF, PTF, as well as the syndesmosis, the anterior inferior syndesmosis, the medial malleolus, the deltoid ligament and its components, the Achilles tendon, 5th metatarsal base, and you can't see it there, or at least not on my screen, but anterior process of the calcaneus as well.
And I think that's critical, that spot midway between the lateral malleolus and the styloid process of the 5th metatarsal. That midpoint is the anterior process. We see it in the lower right-hand photo, and a commonly missed injury. We know that the anterior process fracture or bifurcate ligament injury. And I've seen people go on CC joint fusions, chronic pain, all sorts of problems because there was failure to diagnose this. Certainly the styloid as well, the fifth metatarsal, the avulsion injury, and then identifying, do you have any syndesmotic involvement, with the shuck test and the squeeze test. And if there's a syndesmotic injury, your period of immobilization, is going to be longer. And may even, there could even be some diastasis, that requires, a tightrope, for example. So.
Sure. Definitely been seeing the bifurcate injury a lot in the soccer players, and been kind of new for me. I saw more of it, I think, in the first couple months than I did in my residency, but a lot of players presenting with mild or no ATF pain, but then significant bifurcate pain. So here we have just a couple pictures depicting the syndesmosis. So what Doc touched on, the squeeze test, external rotation test, and there possibly could be surgical intervention. If on stress radiographs, you are seeing the diastasis and instability, and there is no fracture, or there's a previously healed fracture, this could definitely be an indication for surgery as well. And it seems like over the past few years, TUA being a great, popular example of people getting acute syndesmotic fixation as well, whether it's a suture button or screw fixation, like a two-hole plate. Or so some clinical tests, again, squeeze tests for the lateral ankle ligaments, anterior drawer test, push-pull test. We're looking for that dimple sign. Talar tilt tests, muscle testing, especially the perineals and the flexors, and then just dorsiflexion and plantar flexion of the metatarsal phalangeal joint, as well as looking and noting for a Shepherd's fracture or flexor tendon injury. And on the right, you can see a couple images, and we have an animated image coming up as well. But you can see the anterior drawer test here as well, and the Talar tilt test previously. And then I think on the next one we have an image, or I guess the next one after this one. A lot of drawer signs. Well, that's somewhere in here.
If you go back to the other one right here, you see the dimpling. This is a video as well, but I don't know if it's showing up. I have one more. Obviously not running.
Hopefully it'll work, but.
I may have to take it out of presentation to see the video really quickly.
I think these are just pictures.
Yeah.
Okay.
The one on the left's a picture. No, the one on the right's a video.
Oh, I think I posted that one as a pic, Doc.
Oh, okay. But the next one you should have like a little video.
So just some grading, some classification. Grade 1, a partial tear being of the ATF ligament. Grade 2 being a complete tear of the ATF and a partial tear to the CF. Grade 3 being a complete tear of the ATF and a CF. And some authors have a grade 4 where there's a PTF ligament injury, which I've rarely seen in my training experience, I think just a few times, and we haven't done anything to address it. Go to the next slide, please. And so radiographic evaluation, from an academic standpoint, all we're taught the auto ankle rules, who gets an x-ray, some specific guidelines for point tenderness at the tip of the lateral and medial malleolus, distal 6 centimeters, or inability to bear weight or 4 steps immediately after the injury in the emergency department. So really the weight bearing status is a big part of it. I think it's important to mention or just touch on really quick, but of course, in the US, if you show up and you sprained your ankle and you have pain, you're pretty much going to get an x-ray to rule out any osseous pathology. And typically standard views, AP, MO, and lateral of the ankle, and then as well as a medial oblique of the foot, specifically to look for the anterior process of the calcaneus. So associated injuries, we touched on a few of these, but ankle fracture, syndesmotic, high ankle injury, a Shepherd's or Stetus fracture, process fracture, which is the posterolateral tubercle of the talus, talar dome fracture, calcaneal anterior process fracture, a fifth metatarsal base avulsion fracture, a Jones not being as common, definitely an athletic injury, but not as common with this type of mechanism of injury. Sinus tarsi syndrome, and perineal tendon pathology or injury, which is very, very important as well. We'll touch on that. And so here, some more rare associated injuries, but I think important to mention, pseudoaneurysm of the lateral malleolar artery, neoplasm, compartment syndrome, reflex sympathetic dystrophy, or an Achilles tendon rupture. Here on the right, just showing an image of an Achilles tendon rupture, a clinical image. And these are two images, a diagram kind of showing the mechanism. And then on the right, we have an image, a radiographic image of showing an anterior process fracture of the calcaneus. And here we have a fifth metatarsal fracture, again, a Jones with this mechanism injury not being as common. So you can see that it is kind of limited to this styloid process and the mechanism being an avulsion from a lateral slip of the plantar fascia, and then to a lesser extent, also the peroneus brevis.
I think for most of us, if a Jones fracture is seen following an inversion mechanism, it was, it represents an acute on chronic injury. It seems as though that's what the literature supports, and understanding that a Jones fracture is a stress fracture, not typically a traumatic fracture, so to speak, or acute fracture. And if it appears in that setting, generally it was already there and there was acute on chronic type of injury. I think most of these individuals that have had their tibias snap in half, we know the young man for Portland had it happen, and the young man on Louisville, University of Louisville years ago, the soccer player David Villa for Spain, where their tibias just break in half. They have a pre-existing dreaded black line. They have a flaw there, and it just all they need is one little incorrect movement and their bone breaks in half. So acute on chronic has been my experience, and I think the literature supports that when you see a Jones fracture following an inversion ankle sprain.
Yeah, may I say something? I'm sorry to interject on this is a really important point, and a lot of podiatrists make mistakes on this mechanism. It's really important to distinguish what you just said, both of you, is that this base fracture is usually a supinatory fracture, whereas the Jones is usually the foot is planted, it's a pronatory. Yes, the ankle can twist over it after the pronatory injury, but it's usually a pronatory with the foot planted on the ground, and then they fall over it so they think they're supinating it, but and if you look at the original article that Jones wrote, this is like a big pet peeve of mine. The mechanism is completely different, these two types of fractures. So I definitely agree with you. Sorry to interject, but
no, that's great. Yeah, that's awesome. I believe.
Great points. And just continuing on, a couple images of a talar dome lesion and fracture in the next image. So other things to consider. Here, a shepherd's fracture in the top right. You can kind of see a better image of it. And then the images below just kind of showing areas to palpate.
I think the literature supports also that those are, right and left. You can see on the right side, on my right side of the screen anyway, that there is the stidus fracture, and on the left you have an elongate posterior lateral process but no fracture. And I think it's pretty solid that if you have an elongate posterior lateral process on one foot, you also are going to have it on the other. So I think it's a fair comparison. Obviously, the patient would have pain in the posterior ankle as well. But to contrast that a little bit with, for example, bipartite sesamoids, that my experience, and I believe the literature supports that, you're not going to see it so bilateral. Someone could have, I've seen people with bipartite sesamoids on one foot and the other foot did not. And I think that that's pretty common. But I think when assessing the possibility of a stidus fracture, shepherd's fracture, that taking comparative films is a valid thing to do. Whereas for a sesamoid, bipartite sesamoid versus a fractured sesamoid, I don't think that that's as valid as a comparison, right to left.
So initial management for a lateral ankle sprain. We all know RICE or PRICE: protection, rest, ice, compression, elevation, and then questioning NSAIDs depending on the injury. But I put another point down there. One of the first things, I learned when I started my fellowship was it's a little bit different when you're dealing with professional athletes, and icing seems like has changed. the protocol a little bit. I know with the NBA athletes, it's pretty rare that I see them getting iced for anything. A lot of times muscle stimulation and compression and proprioceptive exercises right off the bat are kind of their main treatment plan. It seems like kind of ice is kind of being removed from the equation just to do everything you can to stimulate blood flow and all the good stuff going to the area of the injury.
Yeah, that's been something the last couple of years with our athletic trainers with the heat and Inter as well. If someone sprains their ankle, by the time I get back there, they're not going to be submerged in a cold bath. They're going to have it wrapped, compressed with muscle stim occurring. And so the idea, you know, the ice cube was once the biggest tool in the athletic trainer's toolbox, used for just about everything. Its use has been mitigated to a significant extent, you know, with acute ankle sprains, favoring compression. And the whole concept, you want the good things to get in and the bad things to get out, and ice is going to prevent that.
All right, so continuing on, Jones compression is going to be initial management 0 to 5 days. For a syndesmotic injury, just as Doc mentioned earlier, we definitely are going to increase that weight-bearing immobilization status to 6 to 8 weeks, depending on whether they do or are they a candidate or not for acute surgical intervention. And so you want to, but you know, typically just for the lateral ankle sprain without fracture, you want to limit the period of non-weight bearing to as little as possible. The use of a cam walker for early weight bearing, you know, one of podiatry's best friends. That can also cause a lot of other issues through compensation, but you know, does the job it needs to do. And then you can also consider a bone scan, MRI, CT, depending on, you know, how the patient presents to you and their level of pain. But, you know, most importantly, proprioceptive exercises, beginning rehabilitation as soon as possible. And you can kind of see some of the soccer guys in the training facility for InterCF on the right here, just kind of doing some proprioceptive work and different things.
I mean, a couple of things there, Sonny, like this last point, like that's not was so much the intention, is that we know that with an ankle sprain, you don't put them in a hard cast and you want somebody to be able to weight bear, and you really want to limit any non-weight bearing. We know that weight bearing helps improve the outcome. It helps re-educate the nerve endings in the plantar surface of the foot and in the skin overlying the lateral malleolus. We are never operating on acute ankle sprains. That's probably the biggest never, one of the biggest ones, okay? You're never operating on acute sprains. And I don't care if you've identified it as a 3 ligament injury from the get-go. So we're not putting people in hard casts and non-weight bearing. We're not operating on acute sprains. Functional treatment in the cam boot, promoting weight bearing immediately, and keeping the ankle in a dorsiflexed position, which creates a closed packed orientation of the ATF. It's the potential for it to heal back together better. But weight bearing is critical in these sprains, and anybody who's not willing to put any weight on it, you better do an MRI. Maybe you have more serious injury than you thought. Then again, maybe you have a reflex sympathetic dystrophy. I'm dating myself, a chronic regional pain syndrome patient on your hands as well. So always have to think about that. And certainly if you see anything suspicious on your initial x-rays or your examination, you're going to do an MR right from the beginning. If someone is further along and you're doing rehab, and they're getting worse in rehab, you're going to stop what you're doing and do an MRI. But, you know, that bottom point is essentially we're really never casting hard casts and non-weight bearing. We're really never doing surgery on acute ankle sprains. Functional management in the cam boot, and I think that's pretty solid.
So just as Doc said, functional management, and the cam walker displayed here, as we all know. But yeah, it just puts it, gives the patient the ability to weight bear as soon as possible and ideal anatomic position. And so the rehabilitation phases and prevention, the acute phase, the rehabilitative phase, the functional phase, the return to activity phase. You're going to see, or you should expect to see, a significant pain decrease in the first 2 weeks after injury. I would say, I feel like in our, my experience or training experience, even the first week, but 5 to 33%, some results do vary, do report pain at 1 year. And we're going to talk about that a little bit later. or a few slides later. And you do have a slight increased risk of a sprain of the ipsilateral and contralateral ankle as well.
A couple things here. Clearly, the acute phase is going to involve contrast bathing, muscle stim, compression. The rehabilitative phase, you're going to start to get into some range of motion, weight bearing, TheraBand, things like that. Functional phase, that's where your BAPS board comes in, your proprioceptive exercise and your more advanced strengthening. And then the return activity phase, where you're doing more sports specific exercises for the patient. And a lot of people consider the functional phase to include return to activity. So some people will consider, perhaps most consider, they're just 3 phases of rehab. We know that also that a couple things. One other thing on the Inter-Miami, our experience has been with them that essentially they do so much. Sports science is a much bigger deal than it is in the NBA. And what you're seeing here in this slide is a gentleman getting, before every practice, getting a thermography photograph with the infrared camera. And you can see on the individual's right leg, we have an increased skin temperature. And perhaps this is correlated with recovery from an injury or from a current injury. But they do this thermography. They do that proprioceptive biofeedback that you saw in the last thing. They do some jumping tests to determine landing pressure. They wore the sports bra and with the GPS that tracks their movement on the field. It keeps track of like how much lateral movement, which we tend to see more injuries with lateral movement. So they're in the MLS, at least with the Inter-Miami. Sports science is a part of day in and day out training, whereas you don't see this as much in the NBA. So
absolutely. One of the first things I noticed when working with both teams, and we started off with the soccer team, and I'm going to go see them tomorrow on behalf of Doc. And no, it's something that's used every single time I'm there. It's very interesting. So, and then as Doc touched on, the BAPS board, Biomechanical Ankle Platform System, a lot of the use of plyometrics, toe raises, and other balancing exercise. And then very important too, the lateral side-to-side movements. And here on the right, you can see this gentleman enjoying himself on the BAPS board. And then the last phase, the return to activity phase. So very sport-specific movements, really kind of honing in on what your sport is and all those specific maneuvers, and a lot of preventative strategies as well. And then any possible equipment modifications that may be necessary. And so when can the athlete return to normal activity? And so the $1 million question, it seems like whatever level athlete you are, whether it's the trainers and the executives from the Heat, or the head trainer for InterCF, or parents of a young child that want to get their really competitive child back to sport, it seems like that's always the most important question. What everyone's concerned with is when they can return. And so we've kind of focused on some requirements that Dr. Losito has taught me, but minimal, no edema or swelling. They've got to have a normal gait, no antalgic gait, obviously. But this is a big one, being able to perform a one-legged toe raise. See a lot of patients that get close to this mark, but they can't perform this yet, and they want to return to activity because they feel good. But it's very important to be able to perform a one-legged toe raise, the ability to descend stairs without using a rail, one-legged lateral hop test, and an ankle dorsiflexion test. And I know Dr. Losito, he actually performs these in front of his patients just to really show them and educate them well on what exactly they need to do, just to give the patient a really good understanding of what they need to do to really get back to the level they want to be at in the safest way possible. And here on the right, you could just see the training room with the Heat. You can see some of the trainers working on the guys there. And so ankle braces and tape both reduce the incidence of ankle inversion sprains by increasing perineal reactivity and the reaction time specifically, and strength through direct contact with the skin, the proprioceptors. Braces will be better than tape because tape, the efficacy typically shows a 40% reduction after the 10-minute period, but both do not alter the athletic performance if it's applied correctly. And so orthosis and high top shoes are important to mention as well. And athletes should be braced for up to 6 months following an injury. But there's supposed to be a note here, but high top shoes, it seems like more recent literature has kind of changed in that area, but it doesn't actually contribute to stability at the level of the ankle.
Yeah, I mean, clearly, we've seen everybody go to a low top shoe in the NBA. This trend started about 5-6 years ago. And it's because, the high top shoes do nothing to stabilize the ankle. And that was a big secret for a long time for some people, I guess. We know that braces, tape, and orthotics, they provide some direct mechanical support, and obviously tape being the least. But the neurological component, I know that Doug Ritchie has done some work on postural sway and the nerve endings in the plantar surface of the foot and overlying the lateral malleolus are essentially the nerve endings that provide us with proprioception. And so the stimulation of the plantar surface of the foot, the stimulation of the skin overlying the lateral malleolus, either by tape or by a brace, contributes to the stability. And as much as you can make an orthotic with a valgus wedge, and you can, you could make an orthotic with a high deep heel cup and a lateral clip, and really bring it up high. And I do all that, but yet the neurological component. I mean, we see a little J strap of the inch tape. Studies have shown you put a little J strap with H tape over the 1 inch cloth tape over the lateral malleolus, lateral ankle, and that reduces the incidence of inversion sprains. I mean, for God's sakes, I mean, how much direct mechanical support is there? Like essentially nil. So not a question about like the incidence of ankle sprains in flat-footed athletes. I'd have to say that the inversion sprain is common. It does not discriminate against anyone. And that certainly, to me, my understanding of biomechanics and my experience, that a flat-footed individual is less likely to sprain their ankle than somebody with a cavo-varus foot and a rear foot varus. And, later on in the conversation, we'll talk about the surgery. And if you have that patient with an uncompensated rear foot varus, if they can't get their heel to perpendicular, you have to do that calcaneal osteotomy as well. And whether you're treating a split tear of a peroneal tendon, or whether you're doing a Brostrom or even a stabilization procedure, if they can't get that heel to perpendicular, you need to do that. At least that's the best way to go about it. But by the same token, I think I've seen fewer sprains in flat-footed individuals. And the concept of somebody wearing a shoe that was too cushioned, any type of foot, cavo-varus, cavus, or planus, is going to sprain their ankle potentially using the wrong shoe for the wrong sport, a running shoe for a ballistic sport, for example, an over-cushioned shoe. The concept of trauma, where someone receives, there's actual contact between athletes that created the ankle sprain. But I'd have to say that I think it's more typical. I see more inversion sprains in the cavus feet and the high arched feet, the varus heel, than I see in more of a valgus flat-footed individual. Yeah, Sonny, you can skip through some of this stuff and get to the surgeries and stuff. I mean, this is and talk about this. So chronic lateral ankle instability clearly is the number one complication of ankle sprains. And when people reach this point, when they have a positive drawer, when they've had rehab and they have failed in this, they have tried braces, orthotics, and taping not being so realistic because it requires an athletic trainer to do it, they are a candidate for a surgical procedure. Not to undermine too much of what you're going to say, Sonny, but the reality is the stress testing, in my opinion, is not worth doing. The problems with the high-pake dye and allergic reactions and the technical difficulty with it. I think that MRI is going to give you the information you need to know. And I think performing stress inversion tests, I mean, that was more like why I wouldn't do arthrography anymore. Stress inversion tests, a common peroneal nerve block is not going to anesthetize the entire leg. It's not going to knock out all the pain. Are you really getting a valid tailor tilt or push pull? You know, you got to answer that. You're not going to do a popliteal block in your office. So don't recommend that. All right. And every anesthesiologist, you know, will flip out when you hear that they did when he hears that you did that. But, you know, I think that this is what kind of puts someone set up for a surgical procedure, surgical intervention of an ankle injury. But go ahead, Sonny, sorry.
No, you're good, Doc. Great points. I mean, I definitely have some images on that just to touch on it from an academic standpoint, but we typically stick to our physical exam and imaging, X-ray and MRI. So we can continue on. So just touching on again, stress radiography, just a couple images there, some numbers on, you know, what you would be looking for. But again, we typically don't do this, but in that picture A, you can see the anterior drawer. You can just see the displacement of the tailor body, the talus anteriorly. Oh, here we go. So we actually have our dimple sign here. I thought it was back a little farther, but just a good example of the anterior draw test.
And I find, I don't know if you have the one that the other one that I gave you of intraoperatively, you know, you have your patient under anesthesia and you really get an idea of how much that ankle moves. But if you got someone who's got sprain, had multiple sprains, rehab has failed, taping, orthotics, et cetera, have failed, you've given it 180 days. I think that would be standard in the orthopedic, you know, community, conservative care. They're a candidate for surgery. And I don't think you need any other kind of imaging or even stress testing. And I don't.
Sure, I agree, Doug. Another image of some stress testing.
Yeah, move on this. Yeah. But it's good, but they know all this. Everybody knows this stuff. Good. All right, here we go.
So we're beginning with surgical intervention. So delayed primary ligamentous repair. We're all familiar with the Brostrom procedure. Lateral ankle stabilization procedures, which we'll touch on, this Christmas Snook, Watson-Jones. So these procedures are basically a non-anatomic reconstruction using a tendon transfer. The technique involves any malalignment, which must be corrected to achieve success, as well as, you know, the use of a Coleman block test could be used to distinguish between fixed and a flexible hindfoot varus. And the results for these procedures, you know, one thing important thing to note is there was commonly found subtalar stiffness. And so if we continue on, we'll kind of break more into the surgical intervention procedures. Watson-Jones, you have a picture of the modified Watson-Jones below, but it's a split peroneus brevis tendon is passed through drill holes through the lateral malleolus and the neck of the talus, while the Christmas Snook is going to reconstruct the anterior talofibular ligament and the calcaneofibular ligament using one half of the peroneus brevis tendon routed through tunnels of the fibula and the calcaneus. So surgical management, the outcomes of the studies indicated that delayed primary ligamentous repair actually yields the best and improved results when compared to a more regressive stabilization procedures. Stabilization procedures are more disruptive to the normal anatomy. They're more technically difficult, a little bit less consistency in the results, and they're more likely to get a little bit of over tightening in the ankle based on the literature. So we always typically, you know, initiate with our Brostrom when we're considering surgical intervention. And on the next slide, we'll see more information on the Brostrom. But it's basically an anatomic shortening and reinsertion of the ATFL and CFL, providing stability. It's reinforced with the extensor retinaculum, anterior inferior extensor retinaculum, and distal periosteum of the fibula, which is the Gould modification. And it's very important. There's another article recently that's published this year that's also a big focal point of post-operative results that were greater than a year, showed significant focus on continuation throughout the post-operative months of perineal strengthening with, again, proprioceptive exercises and physical therapy to reduce recurrent strains. And so patients that an ATF with CF repair that was greater than a year, it was noted to be significant, but if it was less than a year post-op, greater than a year post-op, and they weren't doing the perineal strengthening along with the proprioceptive exercises, there was shown to be an increase, a significant increase and the post-operative clinical outcomes, specifically the Taylor tilt test.
And the recent article, Journal of Foot and Ankle Surgery, did propose again that it's important especially if you have subtalar instability, to repair that calcaneofibular ligament. I think the party line for a long time has been just repair the ATF, and you can leave the CF flapping in the breeze. But you are going to get a stronger repair. Now more literature is coming out, especially of controlling that subtalar joint if you repair any rupture of the calcaneofibular ligament. I don't think there's any doubt about that. But I think that the literature is clear that the Brostrom Gould and the Gould modification, over sewing the inferior crus of the inferior extensor retinaculum to that anterior border of the fibula, that provides more subtalar joint stability. So when you do that, along with the ATF imbrication, and then repair the CF, you're getting subtalar and ankle joint, stability. I think the big question is, a lot of people do it with suture anchors now. The internal brace has been very popular. The internal brace has been applied to even ulnar collateral ligament repairs, as one of our Heat players had it from the Steve Shin in Los Angeles, who basically pioneered the use of the internal brace for ulnar collateral ligament. So that's that internal brace, and he's done other baseball players, Drew Brees, Mike Trout, people like that. So he's kind of got that procedure down using that internal brace. But the question is, when do you do a stabilization? I think clearly where you get more complicated with these repairs. I think the standard thing we do now, we scope the ankle, we arthroscopically inspect the talar dome and debride the ankle as necessary, identify any talar dome lesions quickly, then pull out the scope and do open Brostrom with the standard incision. I don't do arthro-Brostroms. I've done plenty of them in the laboratory, but I don't feel as comfortable. So I'll do an open Brostrom repair. But when do you not do that? When do you do stabilization? A failed Brostrom? Sure, I think that's easy for us. Subtalar instability? Well, you could argue that a stabilization might provide more subtalar instability than just the Gould modification or repairing the calcaneofibular ligament. But that to me is the big question, that we'd like to nail it down to something more than the surgeon's opinion or that possibility. We'd like to make it more objective. That's the beauty about returning to activity after an ankle sprain. It's so objective. If they can releve to demi-point, if they can get up on the ball of their foot and balance, they're ready. They're ready to go back. And I think anytime we can eliminate our opinion, it's a good thing. It just makes it more objective.
I agree, Doc. And we were just actually discussing it last week prior to even discussing the presentation. We have a PEDS bilateral patient next week. We're doing Brostrom repair with the ATF and CF repair, and discussed exactly what Doc just said. So just an image of the Brostrom here, and then we can continue on. So just as Doc mentioned, when do you further stabilize, or when you're really doing a stabilization procedure? Failed Brostrom, subtalar hypermobility, an adjunct calcaneal slide osteotomy is very, very important if there is any varus and you need to address it. But I was trying not to focus too much on a company, but we do typically use the internal brace, fiber wire repair with anchors for stabilization. Again, as I mentioned, we have a great case coming up next week where we're going to do the ATF CF repair bilateral. We'll do a scope first, and then possibly address any perineal pathology as well. Young competitive basketball player, pediatric patient.
I mean, we're fortunate here in South Florida. We're just an hour and a half from the Arthrex Center in Naples. And if you ever have an opportunity to visit there, it's outstanding what Reinhold Schmelding, the private owner of this company, has done. And they're so physician friendly. It's amazing. So we're fortunate, a little biased because they're right around the corner. But we saw all sorts of companies, and the residents and fellow get to work with different companies and understand that they're all a little bit more similar than they are dissimilar. So.
Just a couple images. One kind of showing the final result here on the right, where you can see the brace kind of overlying the Brostrom repair, and just some labeled anatomy that we all know.
And we know the Brostrom, the internal brace, any further augmentation with the suture tape is going to be over the top of your repair. One author or one lecturer I was at, remember, he compared the internal brace to like a check rein in horse buggy racing, where that one leather strap that prevents the horse's head from coming down, and it just prevents your repair. Okay, it protects your repair, and that's why you always want to have the ankle slightly plantar flexed when you put that final biotenonesis screw in and tighten down that knotless construct, because your patient will never get back into their high heels if you have them dorsiflexed when you put that in. So keeping it plantar flexed. There was a question too about, and anyone who's like my age, okay, I'm 63 and learned how to do these, will say, wow, we got great results without any augmentation. We did pants over vest imbrication of the ATF, tightened it down, and people are so happy. We love these surgeries, all right? There's big stuff, and it's pretty straight up, okay, what you have to do. I think there has been research to show that, like, for example, with the suture anchors and with the internal brace, that you return, and similar products, okay, I know I keep mentioning that in the one product, but similar products, that they essentially return it back to the native ATF. That when we just do standard pants over vest imbrication, it's technically, when we go into the lab, not as strong as it was originally. Whereas you use some of this augmentation and it becomes just as strong. Now, clinical outcome differences for a recreational athlete or amateur athlete, I don't think it makes any difference at all. And I tell the residents that there's stuff that we put in that you're going, okay, here's what we're putting in. This is kind of the standard now, or I don't want to even use standard of care. I mean, if I'm an expert on a case and someone didn't use augmentation, that I think it's still completely within the standard of care. I don't think the standard of care has been dictated by any companies that tell us we should use these products to augment our repairs. And that goes for Achilles as well. There's a lot of membranes you can sew on there, and there's a lot of different types of suture, and no research has said that any of it makes any difference at all. You got to tension the Achilles properly, and that's the key. All right. There's research that says Vicryl end to end works just as well as a whip stitch of Ethibond. So, we use these different products to improve our outcomes, and sometimes the research says in a lab it's better, but yet do we clinically really see that, in our patients? I don't know. I'd say that the suture anchors are simple enough to put in. It seems like you don't get complications with them. So I'll use them because I think it just reinforces it. But would I be upset if I didn't have to use them on a patient? Would I feel like I would still get a good outcome with end-to-end imbrication of the ligament simply? Yeah, I think the results would be fine. And in a medical legal standpoint, I'm clear to me that end-to-end imbrication, pants over vest imbrication, rather, is what the standard of care requires, not the use of any kind of suture anchors or further augmentation. And I think that seems to go. I mean, you could use augment with PRP, with some kind of, amorphalized or dehydrated chorion or amnion, umbilical fluid. All these are growth factors. You could trephine the calcaneus, or have your friendly neighborhood plastic surgeon come into the operating room and aspirate some fat. We know that most of the stem cells are in fat. And even though in this country, we can't really dissolve the fat and get the stem cells out, at least we're not supposed to. You could do that as well, but I know of no research that says any of this augmentation improves your outcome. I think that a lot of us do it. If it's authorized by insurance, we do it. We throw the kitchen sink at our patients. And I don't know that that's bad medicine, but it is clear, it is important to be clear on what is really making the difference. So those are great questions. Thank you.
Yeah, that's a great point, Doc. And I think definitely part of the, the part of that, it doesn't add too much to the procedure and that it's easy and consistent and our patients don't have a problem with it too. Definitely a big part of it, or in my opinion. So just touching on this really quick, minimally invasive surgical treatments for chronic ankle instability. Got some information from a paper from a few years ago that compared a lot of different studies. Looked at 430, included 33 in their inclusion criteria. We were just talking about a shift in surgery, right before we started. We're doing a lot of MIS bunionectomies at our program in our fellowship. So I just think, I thought it was important to mention this review had kind of broken it down into 4 MIS categories, I guess you could say: arthroscopic repair, non-arthroscopic minimally invasive repair, arthroscopic reconstruction, and non-arthroscopic minimally invasive reconstruction. There's thorough-based, evidence-based recommendations for these procedures, but currently there's just a poor quality of evidence that was insufficient to allow for a high grade of recommendation to support it. So can be used. I think more evidence needs to be there. In my personal opinion, I don't think the incision for this kind of procedure is that significant or that traumatic to the patient. And I think you're able to address quite a bit. I think the only exception would be is if you are using the same incision to address perineal tendon pathology. It does kind of, typically do have to extend the curvilinear incision depending on what your approach is. But I thought it was interesting to mention. Yeah.
Well, yeah, and there was a question about scoping the ankles. I think a perineal injury, MRI, as you well know, I mean, there's some research that says for an ankle, MRI correlates with arthroscopy only about 65%. So we do our MRIs, but they are far from perfect. And so if someone has perineal pain, retromalleolar, inframalleolar, I'll do my MRI. If it says there's a split tear, I'm going to tubularize it. And if I need to deepen the groove a little, and I'm for sure going to tighten up the retinaculum, absolutely. If they have pain there and the MRI is equivocal or negative, I think I'm still going to extend my curvilinear incision and take a look into that area. As far as the arthroscopy, we try to scope all the ankles before we do the open brostrom to look for look at the talar dome and look for any, especially like posterior talar dome injury. We know this is a common, somewhat clandestine injury. To me, if someone has, is rehabilitating their ankle, lateral ankle sprain, and they start having some pain, that's the first thing I think about. Stop what you're doing and let's do an MRI. Let's think about possibility of a talar dome injury. So we try to scope all of them to look for that and look at within the ankle, keep your incision as minimal as possible, although it doesn't seem to be a problematic incision for nerve entrapments or anything like that. And yes, I think scoping is very important.
Definitely, we always scope.
I think doing an arthro brostrom, doing a brostrom procedure, a similar procedure with arthroscopy, and tying those knots and whipping them through the portals. I mean, you need to acquire a certain level of skill to be able to do that. Fortunately, I haven't seen anything that says it changes the outcomes, and I've seen the orthopedists debate it back and forth as well, and they feel the same way. Most of them do it open.
So this is just another recent study, comparison of the effects of reconstructive lateral ankle ligaments using the peroneus longus versus the brevis. This specific study basically showed that both are a good option. They're both successful in restoring stability. So, you have options, but the longus, it showed it to be a little bit more simplistic in the surgical technique, as well as more consistent. And then it just had a less influence of the muscle strength on the foot. And some other options, just to touch on it, I haven't really encountered these before, but prolotherapy and prolotherapy, thermal shrinking of the lateral ligaments using a quote unquote wand, and injectable sugar solution to enhance the proprioception. And we have our works cited here. And thank you all for attending.
Well, it was great, guys. I think we answered a lot of questions. I have one last question though. You talked about, you kind of skipped or not skipped over, but you went over the talar tilt as it's not a reflective I get some work comp patients, and I have had a couple work comp people or adjusters want additional documentation that there was ankle instability, not just my exam. So I've had to provide them with a positive Taylor tilt test on X-ray. So don't forget, some insurances may require that. But the bigger question is kind of along the same lines of if you do get an MRI, and a lot of times if it's chronic, the MRI might not show the true tear of the lateral ligaments, and they may just show some minor attenuation. So sometimes with from an insurance standpoint, we struggle with getting these things approved because of some of those like positive MRI findings or negative MRI findings. I don't know how you want to clarify it, but is there anything that you had trouble as far as proving to either the insurance, the patient, or yourself, like, hey, we need some documentable evidence that's not MRI, that the MRI is false negative, so to speak?
Well, I mean, as we all know, the ATF is, let me see what's in. Okay, good. That the ATF is intracapsular. It really is, as you all know, a thickening in the capsule. Half the time we open it up, the capsule's torn. Okay, there the ATF is torn. Other times the capsule is intact, but I'll take, you know, your curved mosquito and you get into the capsule and you can kind of find the ATF right there. So the ATF can be intact, but it's just kind of a big amalgamation of capsular tissue and scar tissue. And it could just be attenuated. That's a lot of the ladies, a lot of the dancers, you know, their ligaments intact. It's just been all stretched out. So that I have not had a problem with insurances. I mean, if someone has been an ankle injury, repeated injury, failed rehab for months, braces, tape, orthotics, and it's been enough time, even up to 180 days, I've never had an insurance really tell me that we need more information, but it's very possible. We all know that. So under those circumstances, yeah, absolutely. I'd do some stress testing on the patient, but it's just so less than accurate that I don't think it should be part or is part of the typical workup. I think it needs to be brought in as necessary.
Great, thank you. And I think there's one more question there. What is your weight bearing protocol for an open Brostrom with or without suture tape augmentation?
Non-weight bearing for about 10 days. I will think about putting them on, you know, some Xarelto during that time. But a lot of times you used a thigh tourniquet, you know, now they're non-weight bearing. A lot of times I'll have anesthesia, give them a popliteal block afterwards for their anesthesia. And sometimes before the case, depending on what we want to do. But non-weight bearing for about 10 days or so, and then weight bearing in a boot for another 2 weeks. So I do keep them off of it for a little over a week.
Great. I have one question for Sunny. Sunny, you're getting a new job soon, and you are your first, year in practice. You have a patient who's failed some conservative care, and you have an chronic ankle instability. What's your surgical go-to, knowing everything you've learned so far?
No, that's a great question. Depending on which procedure, we've been pretty consistent in what we use in my training, whether in residency and fellowship. But no, I like what Doc had to say about definitely my approach is going to be the Brostrom Gould procedure. My incision is going to be kind of the classic one from the, I guess you could say, posterior, a little proximal to the distal tip of the fibula, kind of peripherally or anterior on the foot. And I would throw the kitchen sink at it as well. I would brace it as well. If a CF repair is indicated, or I think it's indicated based on my physical exam, I would be running that extra suture anchor down to the calc and securing it as well there. And then just depending on if there is any perineal tendon pathology, I do like to visualize the perineals whenever I can, depending on, again, what kind of patient is presenting to the office. But no, if you're asking what company to, then I would probably be using the internal brace. Yeah.
Sounds like a winner to me.
Yeah.
Dr. Schmidt had a question. Can you expand on perineal pathology and lateral ankle instability? What are your strategies with recurrent post-op pain?
Well, I think that the most common cause of lateral perineal pain and besides the garden variety tendonitis would be a split tear. And I mentioned earlier on how they can be a little tricky to find on the MRI, but I highly suspect them if physical therapy fails. Recurrent post-operative pain, I think identifying, I mentioned earlier, I haven't had so many nerve entrapments with Brostroms, but if it's a nerve entrapment, well, I'm going to treat that a little differently. In recurrent pain, I think physical therapy is something we do. But in my practice, that's where I use PRP the most, is when it's a little bit mysterious. I'm not quite sure why someone is having recurrent pain or having pain. That's when I'll tend to use PRP to try and smooth things out and to improve the outcome.
Interesting.
Thank you.
Yeah, that's great. I have one last question regarding the perineal, since we're on the subject. When you have a split tear, is there a specific suture that you use to either retubularize, to use non-absorbable, absorbable? Have you found that using absorbable creates more scar tissue? Does that even come into play? Any thoughts on suture choice when doing those repairs laterally?
I've always done them with Vicryl, 3.0 Vicryl, 4.0 Vicryl, not had any problems. I think making sure that they glide back and forth, making sure that they sit in the groove properly, repairing the retinaculum aggressively. I think those are the keys of the procedure, but I've had no use for using Ethibond or any kind of, non-absorbable type of suture. Some people will use the PDS, which is absorbable, but it'll take a long time. I haven't seen that been a difference maker or something that I considered so much. Always use Vicryl.
Great, thank you.
Can I throw in another question as well? Larissa Schmidt here. Again, thank you all for your time and efforts this evening and putting this presentation together. I've been able to treat quite a few professional athletes, and as an ex/retired athlete, as I like to say myself, what type of stigma or use of diagnostic injections do you find within the professional space? So, for example, with perineal pathology or ankle instability, is it really frowned upon using steroids, or do you find yourself doing diagnostic blocks often in these situations?
Yeah, I'm going to try and stay away from any kind of corticosteroid around a tendon. I think we all kind of feel that way. We've all injected a little Decadron into a sheath and then immobilized somebody. But beyond that, clearly it's a little bit of an untenable situation if you have a tendon rupture after a steroid. So PRP is ideal because it has anti-inflammatory properties depending on how you prepare it, and leukocyte rich or leukocyte poor. I think that I'll tend to do most physical therapy with perineal pain and use the PRP. Did that answer kind of the question?
Yeah, absolutely.
I think we've, at least in my year so far, we've had pretty good results with our PRP injections. And I think the biggest thing there is really just kind of educating and counseling the patient too, to be patient and wait for that 6-week protocol and to really follow all the directions and kind of limit their activity and things like that. And if they are compliant, I feel like we've had pretty good results this year.
Do you use cortisone in the joint ever, or that's usually also frowned upon?
Well, my opinion is if you have a perfect joint, you could use some cortisone there. It's when you have a compromised joint that cortisone is going to lead to its decay post-haste. And Lisa, sorry not to completely answer your question, but yes, I think diagnostic block with local anesthetic is the best and the safest way to help diagnose. I probably don't do that enough. But steroid around a tendon, no. And in a joint though, that's kind of how I feel about it. If somebody has an arthritic joint, I'm going to encourage them to have PRP. It's not going to lead to further breakdown, deterioration of the joint. A perfect joint, you can do a cortisone shot. They're going to be fine in the long run. We know that you don't want to do repetitive cortisone shots. And if you have a joint that's compromised, you give it a cortisone shot, it's going to help for a while, and then it's going to be a lot more worse off, moving forward. And I think everybody would agree with that.
Great. Does anybody else have any questions?
Yeah, I do. I typed it in, but when it comes to tenodesis, if you're hooking the peroneus longus and brevis together, do you think that simplifies the mechanics of the ankle, or does it make it more complex? And what impact does that have on the stability of the ankle?
Well, I don't know if I have enough experience to say. I mean, because the times that I've had, obviously, if you have a peroneus longus rupture, you're catching it early, you're gonna do a side-to-side anastomosis with the brevis. Opposite, yeah. And that if it's chronic, it's not a good idea. I mean, I usually will pull on the tendon. If I still see some flexibility in the muscle, I'll do the anastomosis. If it's kind of fibrosed proximally, I'm certainly not gonna anastomose the two tendons. I think it's gonna diminish the stability of the ankle. There's no doubt. You have only one structure crossing that lateral area. So I think the answer would be that it's going to diminish the stability, but I don't have a lot of practical experience with that.
One other question I have, I see this a lot on total ankles, because a lot of times the patients that come in for ankle replacement, and you look at their ankle and it's just completely trashed. They'll say that they've never actually had an ankle fracture. They had multiple ankle sprains. And those are the same patients that typically have a very posteriorly displaced fibula. So you have to be really, really careful when you do the ankle replacement, because you can easily injure the fibula. What do you think the mechanism of that phenomenon is? Do you think that that's an anatomic variant and made them more subject to spraining their ankle and having an unstable ankle? Or do you think it was the repetitive tears of the ligaments and instability that made the fibula go posterior, and that altered the mechanics of the ankle, leading to arthritis? Do you, based on your experience, because you have a lot of these athletes that have these types of injuries, what do you think is happening? Is it the anatomy is abnormal and that's why they're having these instabilities, or is it the injury that then changes the anatomy?
Because there's usually a combined factor where someone comes down on somebody's foot, or they step on a rock, or they're wearing the inappropriate shoe. See, when you factor those in, it's really impossible to answer that question, because it's not a clean research study. You're not evaluating just two things. You've got so many other factors involved. So I don't know the answer to that question. And I don't know that you can figure out the answer to that question, because there's usually more, people don't just roll their ankle, de novo, spontaneously. There's some kind of inciting factor, and how severe that factor is varies, and we don't even really know. So that's why I'd find it difficult to answer that question. But I agree with everything you've observed with total ankles and that fibula being posterior, although I don't really do those procedures so much. I know about that. Yeah.
Yeah, it's just something that I've noticed on a lot of those patients that need total ankles and they've never had a history of fracture. It's always been a history of instability. They tend to have a very posterior displaced fibula, and I've just always wondered why. I'm curious to see if anybody else has a theory on that.
I think it's the former, that if that was what you had said first, that the fibula, it's just how their foot was, and that made them more likely to sprain their ankle, perhaps.
No, thank you. I was just picking your brain a little bit.
No, I appreciate it. Thank you so much for the honor. Thank you.
Well, if there's no more questions, we're getting towards the end of our time, I think. I want to thank Dr. Lucito and Dr. Sunny Jhanji. I appreciate all your time, efforts. This was great. And I just want to say thank you again. And it was a great lecture. So thanks again.
No,
yeah, and Sunny, we're looking forward to big things from you in the future.
Yeah, Sunny. Up in Bradenton. That's right. No, thank you for the opportunity. We certainly will be available anytime and plan on being a lot more involved, with the Florida Fellowship Society. And congratulations to you, Dr. Bellis, in founding this. And I think it's just done a great thing for our profession. So thank you so much.
Oh, thanks, Dr. Perler, for your co-work on this matter. Thanks.
Thank you all for having me.
All right, gentlemen, thank you so much. Take care.
All right, bye-bye, everybody.
Great job, Sonny. Thank you.
Thanks, Doc.